Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Corinne Rao, internal medicine physician. Today's Kevin MD article is Physician On-Call Compensation, the Unpaid Labor Driving Burnout. Corinne, welcome to the show.
Kevin, thank you for having me. It's a pleasure to be on.
All right. So what's your latest article about?
So the latest article actually was first a post that I made on LinkedIn. And I was a little bit surprised when it started generating comments and reactions, and I started receiving messages. So when I wrote that, I wasn't trying to be provocative. I was just trying to name something that most physicians have lived for years, but we rarely articulate it. And when it resonated, it was not because the experience was new, but because it's shared. And it's shared across specialties, across different practice models, and across generations. And physicians recognized it, and they started reaching out, at which point I then turned it into a Kevin MD article because I thought that it needs more reach. And so here I am today to talk about that.
Now, for those who didn't get a chance to read your LinkedIn post or the article in Kevin MD, what about the article generated such a reaction?
So looking back, I think there was a couple of things. One, as I mentioned, it's such a shared experience that it's largely something that's invisible to those that are outside of medicine. But when you name it, physicians recognize it immediately. And the other thing about it, Kevin, and this part, maybe I would say surprised me a little bit, was that a lot of physicians linked it to burnout. And, we talk about burnout a lot, and we have talked about different factors such as losing autonomy with, physicians getting employed, long hours, EMR systems, metrics, and, a whole bunch of different factors. But what I heard from a lot of the physicians was that call was something that was somewhat of a driving factor when they tried to look back and see what was it about their burnout, what was it that made them so tired and so discouraged. And it emerged as call. And like I said, that kind of surprised me a little bit.
And you specifically mentioned that the term call is just a euphemism to extract free labor from employed physicians who no longer own their practices, right?
Yes. And it actually extends even across that spectrum because when you look at certain specialties, especially mostly our surgical specialties, Kevin, they aren't always employed. It could be a large crew that's providing, certain specialty coverage to the hospital. But in order to do that, in order to operate, they have to be part of call. They have to take unassigned patients from the emergency room. And the reason being, obviously, the hospital needs those patients taken care of. So that's kind of how it grew. And it's become to something where it's just baked into the system and it's just been absorbed. And it's become something that physicians are finding is not really sustainable for them long term.
And there's not a lot of choice for a lot of these physicians when they're asked to take call because hospital privileges are tied to them taking call for that hospital, right?
That's correct. So it's one of those things that's just so unique is that just to practice what you're trained to do, you need to be taking call. And what emerges is that to make it okay or to make it to where it's sustainable, it needs to be a defined shift. It needs to be compensated as labor. And I think that's what was coming out about the article, because what it is currently is basically invisible work. It's work, you're on standby, and you show up, you have to be ready to, do what it is you do. And the next day you just kind of carry on. You carry a full patient load and you're expected to just keep going. And I cannot think of any other profession where this occurs. I mean, an analogy I made in an earlier post was about pilots. just to show that pilots have defined rest periods because they carry a lot of lives in their hands. And one could say, it's the same for surgeons. They have high stakes decisions. They're carrying a lot of weight behind that. And why is it okay for surgeons to work without rest, without sleep, and be expected to just perform?
Now, of course, historically, physicians have taken call pretty much forever. Now, why does the historical justification for being on call no longer applies to today's physician? What do you say to those physicians who say, we've always done it, why can't you do it now?
For a lot of reasons. So in the 70s and 80s, hospitals started having 24/7 availability. And in order to have that, they require physicians. Now, things are not as simple as they were back, even earlier, because, you know about family physicians that took care of their own patients, whether it was in clinic or, rounding in the hospital. Then they went and did an entire clinic day, and then they came back and saw their patients. But if you look at it today, Kevin, it's not sustainable. And a very good example of this, which I do mention in my article, is the hospitalist model. So that grew not because it was a philosophical thing, but it was just not working. It was not functional, the system. No longer could we expect physicians to do both. And that's where the distinction began. So it was actually in 1996 that the word hospitalist was first defined in a New England Journal of Medicine article. And it was occurring before that, but then it started becoming more popular. And I think what's really important is what the hospitalist model did is it turned the same work into a defined shift. And so that shift became finite, like it ends at some point. And the thing about call is it's endless. You're tethered. You're taking call for yourself and your group of, physicians, and one day goes into the next. And it's just not doable. So to answer your question, I think the hospitalist model is a really good example because yes, we did it a certain way, but that way can no longer work in today's complexity of medical care.
Well, let me say I do agree with a lot of the feedback that you've received about call simply being uncompensated work. From a practical standpoint, you can anticipate some of the responses for the hospital. If physicians don't take call, the hospital would likely have to find someone who takes that overnight shift, not only for procedures, but also for primary care as well. And given the clinician shortage, that's going to cost money and it's difficult to find someone who takes those overnight shifts. So, what are some of the answers you could give to these anticipated responses that I'm sure you're going to hear from hospital administrators?
Yes. So let me start in reverse. If we don't make any changes, what we're seeing is that physicians are burning out and they're quietly disappearing. A lot of them are finding other things to do. They're going part-time. They're, just going into direct care models, concierge, whatever, non-clinical medicine. So they're just quietly going to disappear. And that is not going to help your shortage either. So I think it would be better to have that narrative more defined and more spoken about, because here's what the physicians are telling you. Now, when it comes to the cost, one thing that often gets missed but is true is that physician compensation is actually only around 8 to 8.6% of the total healthcare costs in this country. So to anybody who thinks that we make up the majority of this cost, it's not true. Again, I'm going to refer back to the hospitalist model. So rather than expecting primary care physicians to do everything, which you just cannot do anymore, the system did make those functional changes. And there is no reason why other specialties couldn't start to. In fact, we're already seeing some of them doing it. They're just not as widely accepted as hospitalist model.
And I know that just as hospitalists were invented back in the 90s, now we have nocturnists, right? People taking overnight shifts for obstetrics, for instance, that tend to get a lot of calls at night.
Yes. So obstetrics is a great example, Kevin, because it's a high risk specialty. It's very labor intensive. You know, you're doing surgeries, you're doing clinic, you're doing GYN, and then you're also delivering babies. So what they call it is actually a laborist model, where there is a physician who's just going to take care of the laboring patients in the hospital so that the other physicians are able to take care of their clinic patients and their elective surgeries. This has actually already been ongoing since, I want to say, early 2000. It's, again, not widely accepted, but there are certainly high volume and high acuity hospitals that have adopted this.
Now, whenever physicians say they should be compensated by taking call, you're going to get pushback, of course, from people who think that physicians value the money more, and the calling of being a doctor includes taking care of patients all hours of the day. How would you advise physicians to respond to that typical pushback by those who don't understand the nuances of the situation?
So it is true that our altruism, and because most of us went into medicine, we felt like we needed to help people, and that's what we wanted to do. That is absolutely true. But on the other hand, we can't expect that that resource is just infinite. It's just because we are also human beings and we have the same needs as any human being to rest and to recover. We cannot simply just continue to do work that is not compensated. And that is a pain point. So call, Kevin, has been either without any compensation or minimally compensated. And it shouldn't have been that way, but we absorbed it and we kept going. And this is where we're at today. And it's actually labor, and labor has to be paid, has to be fairly compensated. So it's no different. And that does not take away from the fact that we still want to help patients. It's just not doable in the current way that it exists.
Are you aware of any systems that compensate for call or hire overnight physicians to take over call for a primary care group or a surgical group? Are we making inroads of getting that call time better valued?
I think there are places where, basically out of necessity, because they find it so difficult to recruit. Because let's face it, if you're a smaller rural or community hospital and you're trying to recruit one specialist, it's going to be really hard. So you have to balance, what are you losing? You're losing access to that care that that specialist would provide to the patients in your community because you just want to continue in a model that doesn't work in this current system. So you would be better served. To answer your question directly, yes, I think some larger groups do have some leverage and some negotiating power to say, look, it's not that we do not want to take care of your unassigned patients. Medicine is 24/7. It's not, a daytime thing or weekday thing, but this is what we're willing to do for our group to be available. And there has to be some reciprocal meeting back at that point. So I think those conversations are happening. Are they happening a lot? I don't know. But I do hope that the narrative starts to shift, especially when we keep talking about burnout, because physicians are telling me that this is one of the big factors that led them. They didn't want to stop seeing patients or leave medicine, but they also could not just continue to be on call.
We're talking to Corinne Rao, internal medicine physician. The Kevin MD article is Physician on-Call Compensation, the Unpaid Labor Driving Burnout. Corinne, as always, will end with take-home messages they want to leave with the Kevin MD audience.
Kevin, the take-home message is that call is not an infinite resource. Call is labor, and labor must be paid fairly, transparently, and with built-in rest protections. So I think it's time to legitimize that narrative.
Corinne, as always, thank you so much for sharing your perspective and insight. And thanks again for coming back on the show.
Thank you, Kevin, for having me.